Okay, so today we are going to talk about a cardiac cycle. What is a cardiac cycle? These are regular events which occur in the cardiac cycle. It may be electrical or it may be mechanical. From one heartbeat to another heartbeat is called a cardiac cycle. And on an average, the duration of the cardiac cycle is somewhere around 0.8 seconds. So it is less than 1 second. When we consider the heart rate somewhere around 75 beats. So normal cardiac cycle, it's like a start from the start of the heart beat till it ends. So from one heartbeat to just before the beginning of the next heartbeat, whatever events occur, everything, including in mechanical like the contraction, relaxation, increasing the pressure, decreasing the pressure, flow of the blood, and as well as electricals. So causes depolarization, repolarization in the muscles. All those events, when we consider all together, we'll call all those events together as a cardiac cycle. So as we know, there are various phases occur. So there atria moves at its own, and ventricle shows their contraction on its own. So depend upon that, we can divide this cardiac cycle into, or we can describe they occur both simultaneously, but we can describe them in two different phases. One is atrial cycle, and another is ventricular cycle. So but they occur simultaneously. जैसे नहीं कि पहले atrial cycle हो गया, उसके बाद ventricle हो रहा है, फिर atrial हो रहा है, फिर ventricle. No, they occur together. Atrial also going on simultaneously, ventricle also going on. So atrial cycle is also 0.8 second and ventricular cycle is also 0.8 second. So whenever there is a contraction of the muscle, we call it in heart that is as a systole. And when there is dilatation of the muscle, we call it as a diastole. So atrial contraction phase or atrial systole phase is last only for 0.1 second. So this is atrial systole phase, and atrial keep on dilating for rest of the cardiac cycle, that is around 0.7 second. So in that 0.1 phase is contract and pushes the blood into ventricle or squeezes almost all blood into ventricle. While next for 7 seconds it will keep on relaxing and keep on receiving the blood from the rest of the body. इसका मतलब ये नहीं कि atrial सिर्फ 0.1 सेकंड के लिए ही ventricle को blood देता है, but it also gives blood during his diastole phase also, because that time it also coincides with the diastolic phase of the ventricle. Now come to the ventricle cycle. It is more complex and there are more events as compared to atrial cycle, and the events were divided into different phases. So first is contraction phase, that is atrial systole phase, which lasts for 0.3 second, while diastole phase which lasts for 0.5 second. So systole phase, it causes contraction of the muscle and it squeezes the blood from the ventricle, while diastole phase is relaxation of muscle and it causes receiving of the blood. So systole is a ejection phase, while diastole is a receiving or filling phase. In that also, ventricular systole also we divide into different phases. So first, this isovolumic contraction, where the heart is keep on contracting, but the volume of the heart doesn't change, and it lasts for just less than 0.05 second, and then suddenly there is opening of the seminal wall, and now blood will start ejecting from the heart, and that's why it is also called as a ejection phase. And it divided into two phases: rapid ejection phase 0.1 second and slow ejection phase, which lasts for 0.15 second. Then it is followed by the diastolic phase, and it is also like a protodiastole. It is just before the diastole. The heart is about to relax, and that will cause a sudden fall in the pressure inside the heart. But this time, the walls are open, semilunar walls open. But after that, semilunar wall close, and heart will keep on relaxing, but without changing any volume inside the heart. So there is no change in the length of the muscle. There is no change in the length of the volume of the world. That's why it is also called isovolumic relaxation or isometric relaxation, and which lasts somewhere around 0.05 seconds. Some authors consider this protodiastole and isovolumic relaxation in together, and that's why many times they written isovolumic relaxation as a phase which has a duration of somewhere around 0.1 second. Okay, don't get confused. protodiastole and isovolumic relaxation is almost same. Then only difference is in protodiastole there is a opening of the semilunar valve, while isovolumic relaxation semilunar valve is closed. Then come to the rapid filling phase. During this phase, AV valve opens and blood will start coming from the atrial systole and heart will keep on relaxing. So first rapid is there is a high pressure difference between ventricle systole, so it rapidly fills. Then there is a almost blood look like a stasis or stagnant, and blood coming directly from the superior and inferior vena cava directly to the ventricles, and that's called stagnant phase. So that's also called the diastasis or reduced filling phase. And lastly, it coincides with the atrial systole, and again atria squeezes all its blood into ventricle, and that is called last rapid filling phase. So these are the various events which occur, and please don't draw this diagram or don't read this diagram. This is just diagram just I put here to show that how the systolic phase and ventricular phase are coordinated with each other and goes. But actual diagram of cardiac cycle is totally different. So please don't use this diagram for your example point of view. But exam point of view, this is the real diagram of your cardiac cycle. Okay. So first we start with the now we'll club all the events. Atrial events and ventricular events. So here we'll not write like only atrial event, atrial diastole. So here we'll always consider simultaneously occurring ventricular event. So first we'll start with atrial systole. So whenever you will describe cardiac cycle, though it is cyclic event, there is no starting point or ending point, but here we prefer it to start describing it with the atrial systole. So atrial systole is a last rapid filling phase of the coincide with the last rapid filling phase of the ventricular diastole, and atria start contracts. And why will start with atrial systole? Because it also started with beginning of the ECG wave. So first there is a SC node is activated, then AV node is activated, then rest of the cardiac muscle is activated. So SC node is activated along with the atrial contraction. So as soon as SC node activated, after that immediately after that atrial systole, because action potential is spread throughout the atrial cycle, atrial muscles. And during atrial systole, it contracts forcefully, and almost it contributes the 25% of total filling of the ventricle. So atrial systole is very important. So it helps us to increase the stroke volume by squeezing extra blood into the ventricle, and it causes increase in the pressure. So there is almost pressure is almost zero. Okay. So consider on this red diagram. This is ventricular pressure. Okay, sorry, atrial pressure. This red line, dotted line. So as you see, there is almost pressure is almost close to the zero, and there is sudden increase in the pressure, and pressure of the right atrium will can be increased up to 7 to 8 mmHg. At that time, the pressure inside the ventricle is almost little bit more than 0 or 2 to 3 mmHg. So it is always lower than ventricular pressure, and because of that, blood moves from the atria to the ventricle with a high speed. And because of this contraction, it also causes a narrowing of the veins, and that causes decreased blood flow from the vein from atria to the from veins to the atria. So there is venous will decrease, but it will cause a filling of ventricle. Almost 25% of the ventricle is extra filled by the atrial systole. Then come to the atrial diastole, which lasts for almost 7 seconds, and during this diastole, atrial muscle will keep on relaxing, and they keep on receiving the blood from the both superior vena cava, inferior vena cava in the right side, while from the pulmonary veins on left side, and they gradually keep on filling the pressure, and that will keep on increasing the pressure in the ventricle. And from zero, it keep on when pressure goes below zero, it opens the AV wall and causes opening of the AV wall causes blood move from the ventricle, atria to the ventricle, and that causes again fall in the pressure. So this is another phase of the diastole where blood is start going from the atria to the ventricle, and then it slowly keep on filling the ventricle till the point atrial systole comes, and where again pressure increases. So there again atrial systole comes here. It will slowly keep on filling during this phase, and then again there's increase in atrial pressure because of atrial systole. So these are atrial events. Then we'll talk about ventricular events. So ventricular event starts with uh, ventricular systole, and first phase of the ventricular systole is isovolumetric contraction. Now, atria contracts and squeezes all blood into the ventricles, and that time AV wall is open. Now, concentrate on opening and closure of the AV walls. So, if you know the structure of the heart, okay. If you know the structure of heart, this is the right atrium, and this right atrium has a opening to the right ventricle, and this is always one way. So, it allows the blood flow from the right atria to right ventricle. Right ventricle has another opening, goes to the pulmonary trunk, and there is also wall, and there is also one way. It allows blood flow from the ventricle to the trunk. It goes to the lungs. Lungs may say it come to the left atrium. So superior vena cava, inferior vena cava. So pulmonary veins will come, 4 pulmonary veins in the left atrium, and it start filling the left atrium. Now this uh, superior inferior vena cava doesn't have wall. This pulmonary veins doesn't have walls. So there is no role of the wall. But from the left atrium, this is right ventricle. From left atrium, there is a wall which is one way and allows blood only move from left atrium to the left ventricle, and there is a left ventricle here. Okay, this left ventricle has another opening for the aorta, and there is also wall which allows only one way flow. So राइट एट्रियम से राइट वेंट्रिकल जाएगा, राइट वेंट्रिकल से लंग्स में जाएगा, लंग्स से लेफ्ट एट्रियम में जाएगा, लेफ्ट एट्रियम से लेफ्ट वेंट्रिकल जाएगा, लेफ्ट वेंट्रिकल से रेस्ट ऑफ द body. So this is how the blood will move, and it all one way direction occur because of one way opening of the wall. So wall between right atrium and right ventricle is called tricuspid wall, TP. Wall between right ventricle and pulmonary artery is called pulmonary wall, or also called as semilunar wall. Wall between left atrium and left ventricle is called bicuspid wall, or also called as a mitral wall. And wall between left ventricle and aorta is called aortic wall, or also called as a semilunar walls. So please make sure these points about these walls, how it moves from one place to other place. And another important factor, that blood always move from high pressure to low pressure. So जहाँ पे high pressure होगा वहाँ से low pressure में जाएगा. Okay. Now here I will always talk about the pressure and opening and closure of the wall. So what will happen? Now right atrium से blood left ventricle में आ गया, and now left ventricle is completely filled. And now action potential also, or electrical potential from AC node as transmitted to the AV node, or AV node से rest of the heart में जा चुका है, and now heart is about to contract. The moment heart starts contracting, there will cause a sudden rise in the pressure, and the rise in the pressure will causes blood to move from the high pressure to the low pressure. Now pressure inside the ventricle is now become higher than pressure inside the atria, and now blood want to move back. Moment blood want to move back, it will close the AV wall, atrioventricular wall, both bicuspid wall and tricuspid wall, and that produce a rapid or loud sound, and that is called first heart sound. So you will listen the first heart sound in isovolumetric contraction phase. Okay, sorry. First heart sound. You will listen that first heart sound in isovolumetric contraction phase, and that first loud sound you will hear here in isovolumetric contraction phase. Now, semilunar wall is already closed. AV wall is now closed, and now heart is a closed chamber, and but it's contracting. But since the blood can't move outside, so volume cannot be changed, and that will cause a sudden rise in the pressure. Heart is contracting, but volume is not changed. That's why this is called a sudden rise in the pressure. And since volume is not changing, we call it as a isovolumetric contraction. Okay, because heart is contracting but volume is not changed. और कब तक raise होगा? It's from almost from the 2 to 3 mm. It can goes up to, here we'll talk about more about the left ventricular pressure. It goes somewhere around more than 80 mmHg, which is the normal pressure inside the aorta. Aorta में lowest pressure is 80. 80 से कम नहीं होता. So it is goes more than 80. And if you consider the pulmonary artery pressure, so in pulmonary artery pressure, that pressure will go somewhere around more than 10 mmHg, which is a normal pulmonary trunk pressure. So moment pressure goes above the aortic pressure or uh, above the pulmonary artery pressure, that time as the blood always want to move from high pressure to low pressure, so blood try to push the semilunar wall and try to move into the aorta or pulmonary trunk, and that will causes opening of the semilunar walls, and that is end of the isovolumic contraction. Okay, so start कहाँ से होता है? Closure of the AV walls, और end कहाँ पे होता है? Opening of semilunar wall. Okay, once this semilunar wall open and there is a high pressure difference between ventricle and aorta, the blood will move with a very high speed, and that is called rapid ejection phase. The first phase is it start long for 0.1 second, and almost two-thirds of the total blood volume will move. So this phase it will start from point C, and there is a blood will keep on ejecting. Blood will keep on ejecting uh, in this first 1.1 second, and that's almost causes rapid ejection. Now there is aorta, which is a elastic artery and already filled with the blood, और उसमें extra blood आता है, and that causes stretching on the aorta, and that increases the pressure inside the aorta. So aorta के अंदर भी pressure बढ़ना चालू हो जाता है, but ventricle still contracting. ऐसा नहीं कि वो isometric contraction में हो रहा है. During rapid ejection phase also, ventricle is still contracting, and that also keep on increasing the pressure inside the ventricle, but that gives enough time for the aorta to keep on relaxing. So there is a dilatation started occurring in the aorta, and now almost pressure inside the ventricle and aorta is almost little bit same, and that decreases the blood flow from the ventricle to the aorta and bring into second phase of the ejection, and that is slow ejection phase, and which lasts for almost 0.15 seconds, which is two-thirds of the uh, rapid ejection phase. But during this, the blood is flowing very slowly. Though duration is longer, but blood is moving very slowly from the aorta, ventricle to the aorta, or from ventricle to the pulmonary tract, and that's it's almost contribute one-third of the total stroke volume. And this is called slow ejection phase. Now here I am using stroke volume word. What is meant by stroke volume? So stroke volume is the amount of the blood which ejected by the each ventricle. I'm not talking about both ventricles simultaneously. Each ventricle in one cardiac cycle. So amount of stroke volume is amount of the blood which ejected by the each ventricle in one cardiac cycle is called stroke volume. Cardiac output is amount of the blood ejected by the each ventricle in 1 minute. So it is different between stroke volume and cardiac output. So एक बीट में स्ट्रोक वॉल्यूम निकलता है, तो 1 मिनट में कितना निकलेगा? जितना हार्ट रेट होगा. 1 मिनट में जितना हार्ट रेट होगा, हार्ट रेट that will gives you cardiac output. Okay. So now the stroke volume, which is almost one-third of the total stroke volume, will be ejected in the slow ejection phase. Now pressure as the blood is moving out, and that most of the blood also moves with the flow. Now already momentum is there, that's why also blood is moving forward. The pressure difference तो है, but it is very less. But because of momentum also, blood is keep on flowing. And now aorta got enough time and it keep on completely relaxing, and now it start contracting back. So aorta जो relax हो रहा था because of increased flow start contracting back, and also ventricular contraction is almost over. Now here the ventricle is about to relax, and that about to stop the blood flow, and this is the end of systole. Okay, so amount of the blood which ejected during the systole is called stroke volume, but amount of the blood which remain inside the ventricle after the end of the systole is called end-systolic volume. That will be somewhere around 50 ml of the blood. ऐसा नहीं होता कि हार्ट में बिल्कुल blood खत्म हो जाता है. It is always filled with the blood. So 50 ml of the blood will always remain inside the ventricle, and that is called end-systolic volume. And if you see the amount of the blood which remain inside the ventricle at the end of the diastole is called end-diastolic volume, which is somewhere around 130 ml. So amount of the blood which ejected during the systole is somewhere around 80 ml. So stroke volume is on an average of 80 ml. And that we can increase also and decrease also by either increasing the end-diastolic volume or by decreasing the end-systolic volume, depending upon the requirement. But remember these values. So end-diastolic volume is 130 ml, end-systolic volume is 50 ml, and stroke volume is 80 ml. Okay. So this is about the end of the ejection phase or end of the systole. And now it start with the diastolic phase. And diastolic phase start with protodiastole. Now here what happen? It's last for a very small duration, 0.05 second. Here uh, aorta start dilating, but still wall is open because there is a pressure inside the ventricle is little bit higher as compared to pressure inside the aorta, and that will keep the wall open. And now moment ventricle start relaxing, there is sudden fall in the pressure inside the ventricle. So during this phase from E to F, a sudden fall in the pressure, and now pressure inside the ventricle is lower than pressure inside the aorta or pressure inside the pulmonary trunk. And that causes as a rule of the blood from high pressure to low pressure, that causes the blood to flow back from the aorta to the ventricle, and that will close the semilunar wall. And that closure of the both semilunar wall, aortic and pulmonary wall, will produce a snapping sound, very sharp sound will be produced, and that called as a second heart sound. So at this point, there will be second heart sound will be there. So this is how this start the diastolic phase, and it will completely end the systolic phase. And as the blood pushes back, it falls on the closed semilunar wall and bounces back, and that causes little rise in the aortic pressure, and that is called incisura. That you can feel also at the level of the pulse because of sudden rise in the pressure because of rapid fallback or bounce back of the blood on the semilunar wall. Okay, so this is how this protodiastole started, and now it will lead it into complete diastolic phase. And as the AV wall is already closed, semilunar wall is just closed, and ventricle is keep on relaxing. So there is no change in the volume of the ventricle. Still, it is relaxing, and that's why this phase is called isovolumetric relaxation phase or isovolumic phase or isometric relaxation phase. And since the ventricle is closed and it's keep on relaxing with closed chamber and no volume is changed, that causes rapid fall in the pressure. So there is rapid fall in the pressure, and it will continuously falling rapidly and goes down. And once it pressure goes below the ventricular, below the atrial pressure, the blood will try to flow from the atria to the ventricle, and that will cause a sudden opening of AV walls, both bicuspid and tricuspid wall, and that is end of the isovolumetric relaxation phase. So once there is a atria wall opens and atria is still relaxing, but the blood volume accumulating in the atria will create a high pressure, and that's why atria is always at the high pressure, and that opening of the AV wall causes rapid flow of the blood into the ventricle, and the rapid flow of the blood will produce a soft sound, and that is considered as the third sound of the heart. And that third heart sound is not audible by normal stethoscope. We can hear only first and second heart sound through the normal stethoscope. So to listen this third heart sound, we need a special instrument that is called phonocardiography, which amplifies the sound. And and that then you can listen those sounds. And now blood will start moving from the atria to the ventricle, and this phase will last for somewhere around 0.1 second. Then it is followed by the reduced rapid filling, or also called as slow reduced filling or slow filling, or diastasis. Here now atrial pressure and ventricle pressure is almost same, and that is just little bit above the zero. And now it feel like a blood is not moving from the atria to the ventricle. So whatever blood is coming from the major arteries like superior and inferior vena cava, they're directly going from that superior to inferior vena cava, and blood is moves into the directly into the ventricle. So it is just like a atria is just like a bypass. So it is just a way to go from the veins directly into the filling into the ventricles. And if you see, the blood is feel like it is not moving at all, and that's why this phase is also named as a diastasis. So if we want to see this, the rapid filling phase, both slow and fast, will almost contribute this sorry first rapid filling phase and reduced filling phase almost contribute 70% to 75% of total ventricular filling. Okay, and out of this, rapid filling phase contribute more as compared to reduced filling phase. Then come to the last rapid filling phase, which almost coincide with the atrial systole, and that causes, because of atrial muscle contraction, it causes increase in the pressure inside the atria and goes pressure up to the 3 to 4 mm in right atrium and 6 to 8 mm in left atrium, and that causes squeezing of the blood water present in the atria into the ventricle, and that additional 25% blood will come, and that is also causes rapid flow of the blood from atria to the ventricle, and that will produce another heart sound that is called fourth out sound. And that fourth out sound is also cannot be heard by the normal stethoscope, but we need a special instrument. Okay, so that's all about the cardiac cycle. And in this, clinically, sometimes you can hear the third out sound, and that is called gallop rhythm, that you can see in children or a hyperactive or hyperdynamic circulation of the thin wall chested patient. That in that case, sometimes you can hear the third out sound, and that causes called as a gallop rhythm. Then come to the comparison with the right and left cardiac cycles. So there's always a right atrial systole occur just before the left atrial systole, because AC node is present on the right side of the ventricle. So it will take time for the impulses to move from the AC node to the rest of the atria, and that's why it will take little bit more time. Well, right ventricle start contracting after left ventricle, because when impulses coming from the SA node to AV node and from AV bundle, so ventricle receives impulses before the right ventricle, and that's why right ventricle contracts little bit later than the left ventricle. That gives little bit more time for the right ventricle to feel extra blood as compared to left. So if you see the ejection also, left ventricular ejection begins before the right ventricular ejection begins before the left ventricular ejection. Why? अभी आप लेफ्ट वेंट्रिकल तो पहले कॉन्ट्रैक्ट होता है, राइट वेंट्रिकल बाद में. But pressure difference between the right ventricle and pulmonary artery is very low as compared to pressure difference between left ventricle and aorta. So to build the pressure up to the aortic pressure, left ventricle take little bit more time, and that's why left ventricle's ejection start a little bit later as compared to right ventricular ejection phase, and that's why opening of the of the pulmonary closure of the pulmonary wall and seminal wall has a little bit difference, and that difference will be nullified during expiration. So during expirations, the pulmonary wall and aortic wall almost close at the same time, while during inspiration, pulmonary wall close little bit later as compared to aortic wall, and that is called split second heart sound. And that is normal, you can see, But when we are talking about stethoscope with unexperienced ears, so we may not able to hear that difference in a second heart sound. But in if patient has some pathology like a bronchial asthma or something, there's high intrathoracic pressure changes during inspiration and expiration. That time you might hear a two distinct sound in a second heart sound. That is called split second heart sound that you can clinically see. The second thing, this is all occur because of venous return. So during inspiration, there is a decrease resistance to the pulmonary vessels, and there is a decrease pressure inside the pulmonary circulation that causes prolonged ejection phase, and that's why the left side and right side will coincide and causes closure of the pulmonary wall at the same time. Then, what are the different events occur during the cardiac cycle? So, first we'll talk about the pressure, then we'll talk about the ventricles, and then we'll talk about the pressure changes, then volume changes, then we'll talk about the electrical changes. So, before going for that, we'll take a 5 minutes break and then we'll start. So, uh, okay, we'll talk about the pressure changes occurring during the ventricles. So first, we'll start with as all cardiac cycles start with atrial systole. So here also we start with atrial systole. Whenever the atrial systole occur during diastasis, there is a hardly any pressure changes occur in a heart, and that pressure changes during diastasis will almost just little bit above the zero. But during atrial systole, there is this increase in interventricular pressure slightly. It goes higher level. There is little almost 7 to 8 mm in the left ventricle or 6 to 7 mm in the right ventricle. So there is increase in the pressure during the atrial systole, and that causes that AB segment, what we are calling this increase in pressure during atrial systole, and that will A start shows the start of the atrial systole, while B shows the closure of the AV valve. And during this, now ventricle is about to contract, and that closes the AV valve. Okay, so during the ventricular systole, there is a first phase which is isovolumic relaxation. Volume is remain changed, and since it is a closed chamber, the pressure will start rising from B to C directly. A very sharp rise in the pressure, and the pressure changes from 6 to 8 mm to directly goes up to 80 mmHg in left ventricle, while from in right ventricle it goes from the 6 to 7 mmHg till the 10 to 15 mmHg. So this is what changes occur during isovolumetric contraction. Then come to the rapid ejection phase. During that phase, ventricle keep on contracting, and pressure of the ventricle will be keep on increasing, though blood is moving out. So there is no sharp rise in the pressure, but the pressure does rise, and the pressure can go as high as up to 120 mmHg. Okay. Similarly, if you go see for the right ventricle, it goes somewhere around 25 mmHg, as high as up 25 mmHg. So C to D is a peak of the rapid ejection phase. And when during slow ejection phase, the ventricle pressure start declining slowly as the blood is moving out of the ventricle, and volume is start decreasing, and that's why the blood pressure start flowing as the blood keep on moving outside, and it will start coming down, and it will come somewhere around just little bit above the 80 mmHg. So 80 से चालू है 20 mmHg गया फिर से little bit just above the 80 mmHg. That comes with the slow ejection phase. Now come to pressure changes occur during ventricular diastole. So during protodiastole, ventricle is about to relax, and that start falling the ventricular pressure, and ventricular pressure goes below uh, aortic pressure. That will start this EF phase is denote the protodiastolic phase, and during this phase there is a rapid fall in the pressure inside the wall, AV wall. That rapid fall in the pressure will cause a sudden closure of semilunar walls. So the गलती से AV wall close लिखा है, that is called sudden closure of the semilunar wall, but AV wall is not yet opened. So now again ventricle become as a closed chamber, but it is relaxing. That's why it is called isovolumic or isovolumetric or isometric relaxation. And since there is a closed chamber is there and there is starting relaxation, that will cause a sharp fall in the pressure. And from 80 mmHg, it comes to as low as or somewhere around 2 to 3 mmHg or sometimes up to 7 to 8 mmHg. So this is up to H, it comes up to slow mmHg, that is F to G and G to H, that is causes isovolumetric relaxation, F to G, that is called isovolumetric relaxation. Now during this phase, the atrial pressure will be keep on increasing because of accumulation of the more blood into the atria. Now at the end of the isovolumetric relaxation pressure, atrial pressure become higher as compared to ventricular pressure, and that will causes the opening of AV wall. And as the wall is open, isovolumetric relaxation phase end, and it will start with the first rapid filling phase. And during first rapid filling phase, there is a rapid fall in the pressure. So it continues because of ventricles keep on relaxing. And because of the though blood is coming inside the ventricle, there is a rapid fall in the pressure, and pressure can touch as low as 0. So it is just above the 0, but if you see technically it comes to the 0. And after that, end of the rapid falling phase, now atrial pressure and ventricular pressure almost same, just little bit atrial pressure little bit more than the ventricular pressure, and pressure will almost remain just little above the 0, and there is slow filling of the phase will be going on. That is called reduced filling phase, or also called as passive filling phase. That phase also called as diastasis. During this phase, the ventricular pressure is just above the 0. Okay, so these are the various changes occur during the ventricular event. Now come to the pressure changes occur in atria. So atrial pressure changes, many times we cannot measure the atrial pressure directly. So many times we'll check the pressure in the jugular vein. That is called jugular venous pressure wave, JVP. The pressure changes occur in the atria and jugular vein is almost same. So they both will be, we can consider as a similar. So what will happen during atrial systole? There is a rapid rise in the pressure. Pressure can goes up to from slightly 0 above to the, it can goes up to 4 to 6 mm in right side and 7 to 8 mm in left atrium during atrial systole. And then immediately after atrial systole, there is a fall in the pressure, but it followed by the isovolumetric contraction. Now that isovolumetric contraction, that is ventricular systole, during isovolumetric contraction, there is a bulging of the wall, AV wall into the atria. So now this is a this is the atria, this is the ventricle, and this ventricle is guided by this AV wall. So when ventricle contract, pressure will increase inside the atria. That will push this wall inside the atria. And that pushing of the wall inside the atria because of ventricular contraction creates a sharp rise in the pressure. That is C wave. A sharp rise in the pressure because of isometric contraction, that pushing of the ventricle inside the atria. After that, there is an ejection phase started, and then during the ejection phase, the wall come back to its original position, and because of papillary muscle, all this thing contract and pulls the AV walls down, and that reduces the pressure inside the atria also suddenly. And then after that, atrial starts slowly filling. Now, atrial is closed, slowly filling, and that will cause a slow rise in the pressure throughout during ventricular ejection phase, and that is called create a V wave. Okay, during ventricular diastole, there is isovolumetric relaxation. That isovolumetric relaxation pulls the AV rings down, and that there is no pressure will increase in the atria, but you keep on filling, that will keep on increasing the atrial pressure. That is called V wave. During rapid filling phase, when AV wall opens, the blood will move from the atria to the ventricle, and that will cause a rapid fall in the pressure in the atrial pressure, but is still above the ventricular pressure. During diastasis also, there is a During diastasis also, there is almost pressure is continuously above the atria, and at the end of the diastasis, when atrial systole is occur, there is again rise in the pressure because of atrial muscular contraction. Then come to the pressure changes in the aorta. Many times this question asked, and aortic pressure is always ranges between 80 mmHg to 120 mmHg. So during atrial systole, the aortic pressure is 80 mmHg. It is no communication of the atria and ventricle, so it is remain at the 80 mmHg. Come to the ventricular systole. As long as the ventricular pressure is below the aortic pressure, there is no change occurring in the aortic pressure. But as soon as the ventricular pressure goes above the 80 mmHg, that will cause a sudden opening of the semilunar wall, and now blood will start entering into the aorta, and that will start rising the pressure inside the aorta. Now what happened in aorta? Aorta is a elastic artery. Sorry. So here we can draw. So here aorta is a elastic artery, and it is guarded by the semilunar wall, and this is ventricle. So when ventricle contract, the blood of the semilunar wall will open. And the opening of the semilunar wall and causes blood moves into the atria. So aorta. Aorta is already filled with the blood. और उसमें extra blood आता है. That because of elastic nature of the aorta, it causes dilatation of the aorta. And whatever the extra blood comes into the aorta will be occupied by the aorta because of its elastic nature. If there would have been no elastic nature, only small amount of the blood will enter into the aorta, or it could have causes rapid rise in the pressure. That rapid rise in the pressure doesn't occur because of aorta is dilated, and pressure will slowly increase into the aorta, and that goes up to reach up to maximum up to 120 mmHg. And as the pressure reaches to 120 mmHg, it ends the rapid ejection phase. Now here the pressure difference between the aorta and ventricle is hardly anything, and that's why the blood during slow ejection phase, the blood is not moving because of the pressure difference, but blood is moving from the ventricle to the aorta because of momentum, and ventricles keep on contracting during that phase also. But during this phase, now slowly the blood from here, which accumulated here, will keep on moving to the rest of the body, and that will be slowly reducing the pressure inside the aorta also. Though blood is coming from the ventricle, but the rate of the blood coming through the ventricle as compared to rate of the blood moving from the aorta to the rest of the body will be higher, and that's why there is a slowly start falling in the pressure inside the aorta. Now come to the during diastole. During protodiastole, there is a aortic pressure is little bit slightly higher as compared to ventricular pressure, and that causes a backflow of the blood, and that backflow of the blood will causes closure of the semilunar wall. And that sudden closure of the semilunar produce a second heart sound, uh, and blood will bounce on the closed semilunar wall and causes backflow. Now this, so blood moves and that will close the semilunar wall. The blood which flows back will bounce on this semilunar wall and moves back, and that causes sudden sharp rise in the pressure, and that is incisura wave will occur during diastolic protodiastole. Sorry, during protodiastole, this sharp rising that is called incisura, that we can feel also during a pulsation. And also if you make a peripheral pulsation, that time also we can see this incisura, that is also called as a dicrotic notch when we are recording the radial artery pulse. Then during the rest of the diastole, AV wall is almost closed, and blood will be slowly moving from the aorta to the rest of the body, and slowly pressure will start falling, and it come back to again is towards the 80 mmHg. Okay, that's about the pressure changes. Now we'll talk about volume changes occurring during the during cardiac cycle. First, we'll talk about the volume changes occurring in ventricle. So this is the graph for the volume changes. And here, if you see, the volume is ranges from 50 mmHg to 30 mmHg. So it is not never like a ventricles are empty of the blood. So during atrial systole, there is rapid filling phase, and during that phase, it is blood volume of the ventricle somewhere around just little above the 100, and from 100 it goes to the 30 mmHg. So extra 25 ml blood will be already filled into the already filled ventricles. Okay, that occur during the atrial systole, and ventricular volume will be increased from during this section to this. So 25 ml blood will be added into the ventricle, and that will cause total ventricular volume, that is end-diastolic volume, somewhere around 130 ml. And during ventricular systole, there is isovolumetric changes, and during this phase, there is a B to C. During this phase, there is no change in the ventricular volume. Then come to the ventricular ejection phase. During rapid ejection phase and slow ejection phase, together almost 80 ml of the blood will be ejected from ventricle to the aorta or pulmonary trunk, and that is all called as a stroke volume. And out of this, 65% of the blood will be ejected in rapid ejection phase, and remaining 35% will be ejected in slow ejection phase. And what blood remain inside the ventricle is somewhere around 50 ml, and that is called end-systolic volume of the ventricle, or end-systolic volume of the blood, or end-systolic volume. During protodiastole and isovolumic ejection, there is no change occurring in the ventricle, but as the phase started, then they slowly blood will start filling into the ventricle, and almost 75% of blood will fill during the rapid ejection phase and slow ejection phase. First rapid ejection phase and slow ejection. First rapid filling phase and slow rapid filling phase. Almost 75% of the total blood will be accumulated, and remaining 25% of blood comes during atrial systole. Now come to the heart sounds. There are four heart sounds in the heart which causes, and it's reported as a first heart sound. In the sequence, they appear into the cardiac cycle. So first heart sound occur because of closure of the AV valves, both tricuspid and bicuspid, and it occurs during the phase, just at the beginning of the phase of isovolumetric contraction. If you try to see characteristics, it is a long and soft, and it has a duration of around 0.15 seconds and frequency about 24.44 hertz, and it's more look like a sound lub. So पर आप एक्चुअली वो हार्ट साउंड सुनते तो कभी लब डब ऐसा सुनाई देता है. तो इट इज जस्ट हाउ इट डिस्क्राइब. सो जब एक डॉक्टर आपको एक एग्जामिनर पूछेगा फर्स्ट हार्ट साउंड कैसा है, सर लब सुनाई दिया, दूसरा डब सुनाई दिया, डोंट से ऑल दोस थ्योरेटिकल, and try to understand the quality of the sound by listening the more and more heart sound. Now where we can hear the first heart sound? So we can hear based this first heart sound on the tricuspid and mitral area. It doesn't mean that we cannot hear this heart sound in the other part of the pericardium, but it can hear based on tricuspid and mitral area. So mitral area, where it is located exactly at the apex of the heart. So first you need to palpate the apex of the heart, and then you need to auscultate on the apex of the heart. While tricuspid area will usually located in the fifth intercostal space on the left side, just close to the sternum, or we also call it parasternum area. So in those both area, you can auscultate this first heart sound, and you can find this the clear quality of the first heart sound in these areas. On phonocardiogram, this shows a recording of single groove of the waves of 9 to 13 waves, with the amplitude start with the small and then slowly rise to higher crescendo and decrescendo type of the waves you can see here. The correlation for heart sound is usually correlated with the peak of the R wave of the ECG. Then come to the second heart sound. It is occur because of the closure of the semilunar wall, and this is usually occurred just at the beginning of ventricular diastole, or also we can call it as the beginning of ventricular isovolumetric relaxation. So isovolumetric contraction से पहले लगता है, and this is before isovolumetric relaxation. It is of short duration, 0.1.2 second, a loud and high pitch sound. The frequency of somewhere around 50 hertz, and it sounds more like a dove. बहुत बार आपको सवाल पूछा जाता है कि फर्स्ट हार्ट साउंड और सेकंड हार्ट साउंड में आप कैसे डिफरेंशिएट करोगे. सो फर्स्ट हार्ट साउंड लॉन्ग है, सेकंड हार्ट साउंड शॉर्ट है. 0.03 सेकंड का कोई इतना अंदाजा नहीं लगा सकता. सो प्लीज डोंट गिव दोज आर्ग्यूमेंट when you are trying to differentiate between first heart sound and second heart sound. Then where we can auscultate this heart sound, those where we can best hear this heart sound, those areas called aortic and pulmonary areas. While aortic area is on the right side of second intercostal space, while pulmonary is on the left side of the second intercostal space. Both are close to the sternum. And phonocardiogram, it is 4 to 6 waves has been shown with a very almost same amplitude throughout the waves, and it usually coincide with the end of the T wave of the ECG. Then come to the third heart sound, which is occur because of the turbulence which produced during the first rapid filling phase of the ventricular diastole. And this is very heart sound is very short, soft, and low pitch, and duration is almost less than 0.1 second. Normally, you cannot hear through the stethoscope. And on phonocardiogram, it shows 1 to 4 waves which are grouped together, and it is this heart sound is appear between T to P waves on ECG. So third and fourth heart sound is always with the rapid filling phase. So third heart sound with the first rapid filling phase, fourth heart sound with the last rapid filling phase. Okay. Second thing, many times you can hear this third heart sound with a normal stethoscope when a person is a thin chested wall and hyperdynamic circulation, or in many times in a pediatric age group, 2 to 5 age group, you can hear this third heart sound. So when you will hear third heart sound with the stethoscope, so now it will not hear like a 2 lub dub lub dub. There is a 3 heart sound simultaneously. That is called gallop rhythm. Then come to the fourth heart sound. It is here during the last rapid filling phase, and it is almost not audible in any condition. Clinically, आपको stethoscope से सुना ही नहीं देगा. Very short and low pitch sound, and its duration is somewhere 0.03 second, and frequency is also somewhere 3 hertz. And on the phonocardiogram, 1 or 2 waves you can see with a very low amplitude, and it is many times it is merged with the first heart sound also. And correlation ECG, it just lies between the end of the P waves and start of the Q waves. Then come to the abnormal heart sounds. These are called the cardiac murmurs, and the mechanism of how it produces, it is because of turbulence in the blood flow. So when turbulence can occur, when there is normal blood flowing through the small orifices, or more blood is flowing through the normal orifices, or blood is flowing through the abnormal orifices. Orifice means holes. Okay. So जब normal blood or holes flow, that is called stenosis. So whenever the walls are difficult in opening or causing narrowing of the wall, that condition is called stenosis, and it can cause, with any chronic inflammation, can cause fibrosis and create those stenosis. These are called valvular stenosis, and that can produce murmur. Mitral stenosis can be there. It is one of the common tricuspid aortic stenosis and pulmonary stenosis. Then, when there is more blood is flowing through the walls, like in causes regurgitation. So the wall is not closure properly, so blood is moving in opposite direction of the wall. So during regurgitation, or also called as the valvular incompetency, blood is moving back to the wall, and that produces the murmur. Then during abnormal openings like septal defects, ventricular septal defect and atrial septal defects, during that phase also there is causes a murmur. And then contraction of aorta, when aorta is narrowing, that time also it produces the murmur. The another condition, special patent ductus arteriosus. Here it is congenital disorder. In birth, there is a ductus arteriosus which connect the pulmonary trunk and aorta to each other, and it immediately after birth it usually close, but sometimes it fail to close, and that remain open, and now blood will move from the aorta to the pulmonary artery, and that also produces a murmur. So there are various different type of the murmur: systolic murmur, diastolic murmur. Systolic murmur is produced during systole, diastolic murmur produced during diastole, and then sometimes a continuous murmur is present throughout the cardiac cycle. And depend upon the site, also the murmur will be there. Aortic wall murmur is best heard in aortic area, pulmonary wall based in pulmonary area, mitral murmur based in mitral area, but tricuspid murmur heard better in tricuspid area. Then come to the duration of the systole and diastole. Normally, I say with normal duration of the cardiac cycle is somewhere around 0.8 seconds. So systole will 0.3 second and diastole will 0.5 second. It is more related to heart rate. जब भी आपका हार्ट रेट बढ़ेगा कार्डियक साइकिल का ड्यूरेशन कम होगा. जब भी ड्यूरेशन कम होगा तो द ड्यूरेशन विल कॉम्प्रोमाइज ऑन systole part and not on the diastole. Sorry, compromise on diastole part and not on the systole part. So duration of the systole almost remains same even if there is increase in heart rate. But what compromise is usually compromise the duration of diastole. So that will cause us decrease venous return or decrease end diastolic volume, and that can reduce your stroke volume. So that's all about mm, abnormal, cardiac cycle, and there is some applied aspect. This is we can talk some other day. Okay. Thank you very much. Have a nice day.